Greetings and welcome to Week 1. My name is Rick Leisman and I will be the guest lecturer for your overview of the first week's course content. During your introductory week, we will explore the history of medicine and the delivery of healthcare in the United States. We will then shift to differing themes of accrediting and regulatory agencies. In this first slide, let's take a moment and review a brief history of healthcare in general. Outlined are the different ages of medicine that we, as humans, have experienced throughout time. Prehistoric medicine refers to a time frame before we, as a human species, were able to read and write. Understandably, this stage in healthcare covers an incredibly large amount of time and ultimately varies by the specific cultures in question. Evil gods and spirits caused disease, and priests were able to drive these spirits away in a general sense. Ancient medicine. In this age, there was still this widespread belief that evil entities caused illness. Similar stances on how sickness occurs remains, but now we have the ability to read and write to preserve our findings so that we can influence the future of medicine. Medieval medicine. We often associate the term medieval to Europe, specifically Western Europe, and medieval medicine provided a somewhat diversely unique approach to care in Europe. Theoretical assumptions, mixed with religious and spiritual preferences, formed that period's social consensus regarding care. Frankly, an entire course could be dedicated to this topic alone. Renaissance medicine. The Renaissance of medicine is an interesting topic because it is a time in our past where we clearly pull ourselves out of a medieval approach to care and influence how we move forward as a species. During this time frame, we develop a more intimately in-depth understanding of anatomy. This was a very controversial topic then because it was done by dissecting cadavers. The knowledge gained from these practices have had a tremendous impact on the development of care, but the methods have fairly been questioned in our more recent history. Lastly, in an area that we live in currently today, we move on to modern medicine. This is truly how we see the delivery of care today, as well as into the near future. Now let's turn our focus to the continuum of care and how it can be dissected and classified. Continuum of care represents the complete range of health services available. We can think of care in 4 categories: primary care, secondary care, tertiary care, and quaternary care. Primary care is a level of care at a basic level. Think about when you receive your annual checkup with a primary physician. This is an example of that. Secondary care is a level of care provided by a specialist. These types of visits typically come via referral from your primary care provider. Tertiary care is a type of care that takes place in facilities where advanced investigative abilities exist. These types of experiences come from a referral from primary or secondary care professionals. Quaternary care can be thought of as an extension to tertiary care, in that it is essentially an advanced form of healthcare delivery. Experimental medicine and some types of uncommon diagnostic or surgical procedures are considered quaternary care. Now that we understand how care is classified, let's move on to how healthcare organizations are classified in terms of ownership. We can classify healthcare organizations into 3 main categories: government, not-for-profit; proprietary, for-profit; and lastly, voluntary, not-for-profit. Government-supported hospitals represent roughly 25% of healthcare organizations across the U.S. The VA is a perfect example of a healthcare organization in this specific category. The Department of Defense is another. Proprietary hospitals represent 15% of health organizations in the U.S., and these institutions are owned by corporations or private foundations with a for-profit status. Lastly, voluntary hospitals make up just at 60% of all healthcare organizations across the U.S. They are not-for-profit and are typically operated by religious institutions or other groups in the U.S. How are healthcare facilities organized in terms of structure and operations? At the top of an organization's hierarchy, there's the governing board. Members typically serve without pay and are professionals from the business community outside of healthcare. This group has the absolute, ultimate authority and responsibility for the organization as a whole. Other common names for this group consist of boards of trustees, boards of governors, and board of directors. A hospital's administration serves as the middleman between hospital staff and governing boards. Administrators are those healthcare professionals developing strategy and goals for the organization. The following roles make up this group: Chief Financial Officers, Chief Information Officers, Chief Operating Officers, as well as Chief Medical Officers, Chief Executive Officers, and many other C-suite type roles. The medical staff makes up the licensed professionals of this institution. This contains physicians, nurse practitioners, etc. Hospital departments are those individual organizations within the healthcare facility that provides care. Think physical therapy, surgical services, oncology, etc. Now let's think about services. Services can be thought of as the actual care activities rendered to patients during their continuum of care. Remember that continuum of care is the entire spectrum of how a patient seeks care. It can be as simple as visiting your doctor or as complicated as a highly complex surgery. In either case, the patient is seeking out a specific service from a healthcare professional. A committee is a grouping of individuals that are formed to tackle a specific project. In the last few years, the United States switched from ICD-9 to ICD-10 terminologies to classify and code a patient's diagnosis, symptom, or illness. Committees, using this as an example, were formed to tackle how this conversion will take place, and all departments likely had representation so that all needs and concerns were addressed prior to the specific go-live date. For a committee to be successful, it must have a clear purpose, charter, and even more so, it must have active participation from all members. The Health Information Department is responsible for keeping patient information and guarding the access of this information in accordance with local, state, and federal laws. Health information services include cancer registries. These professionals collect cancer data from a variety of sources and report this data to the required agencies for statistical analysis. They work closely with a very diverse grouping of healthcare professionals. Honestly, there's a ton of information about this specific group, and I cannot understate how important they are. Coding and abstracting. Coding is the process of physically assigning codes to procedures, diagnoses, and services rendered. Abstracting is the process of generating statistical reports based off of information collected to provide administrators with the quantitative tools to make appropriate decisions relative to quality of care. Think about an analysis related to why readmission rates are going up. The types of data collected from this is an example of how that process shakes out. Image processing. This is the process of converting paper records and images into digital copies that will reside within the electronic health record. Due in part to government policies, which we'll get into later, a majority of documentation is already captured within the EHR, but there are still some forms of documentation that need to be processed by this group. Incomplete record processing. Honestly, the name says it all. This is a group that analyzes charts post-discharge to ensure that all components are present per that specific organization's order of assembly. Incomplete information is updated to ensure that charts are always complete. Medical transcription. This involves the translation of dictated reports directly into a patient's chart. Historically, providers would dictate their findings via recorder, and that would be transcribed by a specific individual into the patient's chart. Recently, software has been rapidly deployed across the entire health landscape that allows for transcription by a provider directly into the patient's chart. There are several different types of software out there, but the limitation is that these fields are often non-discrete. That means they're just bulks of text. So an analysis on quality becomes somewhat difficult because it requires manual investigation compared to discrete fields. Record circulation. Quite simply, this is the retrieval of patient records for a variety of use cases. Release of information processing. This is the process of generating requested information through a formal release of information process. This specific group is responsible for validating requests for authenticity as well as executing on the requests per the security privileges of the requester. This was an incredibly brief overview of vital service lines found within a healthcare organization. Let's review this in terms of our personal lives to ensure that we absorb it. Take a moment to reflect on each of these individual entities. Have you ever experienced direct interaction with any of these groups or processes? If so, what was your experience like as a whole? Now that you've reflected, allow those thoughts, those feelings, those experiences to spill over into all of the other activities that we'll take part in week 1. Prior to discussing the various accrediting agencies out there, let's reflect on what accreditation is. Accreditation is a process that healthcare organizations undergo to demonstrate that some predetermined level of quality or standard has been met. The important part here is that the process is strictly voluntary, and these standards reflect operations that exceed what is required by law. Most organizations will state that even though this is voluntary, being accredited is incredibly vital to their specific ability to operate both functionally and financially in their respective communities. Below and in the next slide, we'll list several different accrediting agencies. A table can be found on page 35 of your course text that lists all important details about these very important organizations. Continuing with our list of accrediting organizations, here are a few more, and I'd like to underline one of them just a bit. In this first bullet, the Joint Commission, formerly known as the Joint Commission of Accreditation of Healthcare Organizations, this is important because this specific institution was deemed as an acceptable equivalent for CMS inspections performed on site at a regular interval. These inspections consist of surveys and interviews. If you've ever been present at a facility during this specific week, it is a flurry of activity. These audits are directly linked to the funding for a facility in a variety of different ways. Anytime you assign a dollar to an outcome, it becomes even more vital to the organization to be successful here. I'd encourage every student to take a bit of time to explore the CMS and Joint Commission websites, as they contain a wealth of information that goes above and beyond what's listed in the course text. Let's quickly review federal legislation that has directly impacted the healthcare industry in recent years. First up, the Deficit Reduction Act of 2005. This act provided states with the flexibility to make significant reforms to their Medicaid programs that sometimes mirrored that of commercial insurance. Second, Patient Safety and Quality Improvement Act of 2005. This was signed into law on July 29th of 2005. The goal of this act is to improve patient safety by encouraging voluntary and confidential reporting of adverse clinical events that impact patients. This frankly was huge. Third bullet, Tax Relief and Health Care Act of 2006. This includes a package of tax extenders and provisions affecting health savings accounts, as well as many other provisions in the United States healthcare industry. Next up, the Genetic Information Non-Discrimination Act. This act prohibits group health plans and health insurers from denying coverage to a healthy individual or charging that person higher premiums based solely on a genetic predisposition to developing a disease in the future. For example, if my father had congenital heart failure, and that was thought to be genetic, this act would prohibit my insurance provider from jacking up my health rates or denying coverage altogether. Next up, the American Recovery and Reinvestment Act. This act is commonly referred to as the Stimulus or the Recovery Act. It was a stimulus package enacted by the 111th United States Congress in February of 2009. It was signed into law that same year, and it includes a significant amount of funding for a variety of efforts, including the partial funding for EMR implementations. Next up, the HITECH Act. The Health Information Technology for Economic and Clinical Health Act was enacted as part of the American Recovery and Reinvestment Act, and this is the specific component that promoted the adoption and meaningful use of health information technology. Last on this list is the Patient Protection and Affordable Care Act. This is commonly referred to as the Affordable Care Act, or nicknamed Obamacare. It's the United States federal statute that was enacted by President Obama that guaranteed a variety of different components of healthcare coverage for citizens in the United States. That last slide allows us to land on week one. During this week, we reviewed a wide-ranging array of topics from the history of medicine around the world to the grouping of accrediting agencies in the United States. In week two, we'll look to review different careers found within the health information management community, as well as HIM professional associations. In addition to this, we'll also review various managed care models and long-term care offerings in the United States.